Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 225 of our Pharmacotherapy MCQ series, which majors in infectious diseases. And the first question reads, which of the following antibiotics is bacteriostatic against sensitive strains of Staphylococcus aureus? Is it A. ceftaroline, or B. daptomycin, or C. linezolid, or D. oxacillin, or is it E. vancomycin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. linezolid. I will justify why. Linezolid is a protein synthesis inhibitor, and while bactericidal against Streptococcus species, it is bacteriostatic against Enterococci and Staphylococci. Please advance to the next question. And the next question reads, which of the following antibiotics is not a protein synthesis inhibitor? Is it A. azithromycin, or B. ciprofloxacin, or C. doxycycline, or D. gentamicin, or is it E. linezolid? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. ciprofloxacin. I will clarify why. Fluoroquinolones act through inhibition of DNA topoisomerases. Aminoglycosides, tetracyclines, macrolides, lincosamides and streptogramins are all protein synthesis inhibitors. Please progress to the next question. And the next question reads, what gene mediates oxacillin resistance in Staphylococcus aureus? Is it A. ARM-A, or B. MAKE-A, or C. TET-A, or D. VAN-A, or is it E. VAN-B? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. MAKE-A. I will explain why. The MAKE-A gene encodes PBP2A, a penicillin-binding protein that confers oxacillin resistance. Please progress to the next question. And the next question reads, a patient is admitted with cholangitis and a liver abscess. The abscess was aspirated and cultures grew Enterobacter aerogenes. The isolate was reported to be susceptible to ceftriaxone, and so he was started on that agent. He clinically improved over the next few days, but then began to have recurrent fevers, and his liver abscess had reaccumulated when his abdominal imaging was repeated. A percutaneous drain was placed and cultures again grew Enterobacter aerogenes, though now resistant to ceftriaxone. So my question to you is, what is the most likely mechanism of antibiotic resistance reflected in the different susceptibility profiles? Is it A. AMP-C induction, or B. efflux pump, or C. ESBL production, or D. Metallo-beta-lactamase production, or is it E. porin production? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. AMP-C induction. I will clarify why. Some bacteria, most notably some Enterobacteriaceae, have chromosomally determined AMP-C beta-lactamases that can be expressed at high levels after exposure to beta-lactams. This can cause clinical failure even if an isolate initially seems susceptible in vitro. Please progress to the next question. And the next question reads, an Escherichia coli isolate is submitted for susceptibility testing. It is resistant to ampicillin, ceftriaxone and aztreonam, and susceptible to cefoxitin, cefepime, ertapenem, piperacillin, tazobactam and ciprofloxacin. This pattern is suggestive of drug resistance mediated by what mechanism? Is it A. AMP-C or B. cell wall modification? Or CESBL, or DPBP alteration? Or is it E. porin production? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is CESBL. I will explain why. Extended-spectrum beta-lactamases confer resistance to third-generation cephalosporins, but not cefamycins or drugs containing beta-lactamase inhibitors. Please proceed to the next question. And the next question reads, inducible resistance to MLSB antibiotics in Staphylococcus aureus can be unmasked with exposure to what antibiotic? Is it to A. doxycycline, or B. erythromycin, or C. methicillin, or D. trimethoprim-sulfamethoxazole? Or is it E. vancomycin? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. erythromycin. I will clarify why. Macrolide, lincosamide and streptogramin antibiotics have a common site of action on the 50S ribosomal subunit. Acquisition of erythromycin methylase, abbreviated as ARM, genes can cause resistance to these drugs through methylation of the target site. Expression may be constitutive or inducible. Isolates with inducible resistance will test as clindamycin susceptible but erythromycin resistant. When tested against both agents at once, the isolate will demonstrate resistance to clindamycin. This is the basis of the D test. Please proceed to the next question. And the next question reads, JKL, a 45-year-old man presents with a new diagnosis of HIV and cerebral toxoplasmosis. JKL was started on sulfadiazine and pyrimethamine, as well as raltegravir, emtricitabine and tenofovir. 3 weeks later, JKL is admitted with nephrolithiasis. Which of his medications would be most likely to cause development of renal stones? Would it be A. emtricitabine, or B. pyrimethamine, or C. raltegravir, or D. sulfadiazine, or is it E. tenofovir? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. sulfadiazine. I will clarify why. High-dose sulfonamides can cause crystalluria. Some antiretroviral agents can cause crystalluria as well, most notably indinavir and atazanavir. Acyclovir is another drug that can be associated with crystalluria. Please progress to the next question. And the next question reads, HLA-B*5701 testing can be used to predict hypersensitivity to a drug. Which of the drugs listed below is it? Is it A. abacavir, or B. atazanavir, or C. efavirenz, or D. lamivudine, or is it E. nevirapine? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. abacavir. I will explain why. Abacavir hypersensitivity can be predicted by testing for the HLA-B*5701 allele. The syndrome can be life-threatening and can manifest with fever and other constitutional symptoms, rash, nausea, vomiting, diarrhea, cough and dyspnea. Please advance to the next question. And the next question reads, the K103N mutation confers resistance to which of the following antiretroviral medications? Is it to A. efavirenz, or B. emtricitabine, or C. etraviron, or D. raltegravir, or is it E. rilpivirine? And the correct answer is A. efavirenz. K103N is the most common mutation associated with efavirenz resistance. This mutation also confers resistance to delavirdine and nevirapine, but not rilpivirine and etravirine. Please proceed to the next question. And the next question reads, all but which of the following drugs would most likely be effective against acyclovir-resistant herpes simplex virus? Would it be A. famciclovir, or B. foscarnet, or C. ganciclovir, or D. penciclovir, or would it be E. valacyclovir? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is B. foscarnet. I will justify why. Most acyclovir-resistant HSV isolates are thymidine kinase deficient, and therefore unable to phosphorylate HSV into the triphosphate form, in which it can act as a DNA synthesis inhibitor. The same phosphorylation mechanism is required for ganciclovir activity, so thymidine kinase deficient viruses will also be resistant to ganciclovir. Foscarnet does not require this phosphorylation step. Please advance to the next question. And the next question reads, what is the mechanism of action of amphotericin? Is it A. increased cell membrane permeability through binding to ergosterol, or B. inhibition of 1,3-beta-glucan synthesis, or C. inhibition of conversion of lanosterol to ergosterol, or D. inhibition of fungal squalene epoxidase, or is it E. inhibition of nucleic acid synthesis? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is A. increased cell membrane permeability through binding to ergosterol. I will clarify why. Amphotericin is a polyen macrolide antifungal agent that acts through binding ergosterol, a prominent component in the cell membranes of most fungi. It leads to the formation of ion channels, composed of amphotericin B multimers, that causes cell death. Please progress to the next question. And the next question reads, a pregnant woman comes to clinic for a travel consultation. She is planning to travel to Guatemala. What is the safest drug for her to take for malaria prophylaxis? Is it A. atavaquone proguanil, or B. doxycycline, or C. chloroquine, or D. mefloquine, or is it E. primaquine? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is C. Chloroquine. I will explain why. All of the other drugs for malaria prevention, including atovaquone proguanil, mefloquine, doxycycline and primaquine, are teratogenic or do not have sufficient evidence to support safe use in pregnancy. Chloroquine-resistant falciparum malaria is widespread, but in some areas, including Guatemala, most cases of malaria are caused by Plasmodium vivax and no chloroquine resistance is reported. If a pregnant woman is considering travel to a malaria endemic region, and the travel is not urgent, counseling to consider rescheduling the trip until after delivery should be considered. Please proceed to the next question. And the next question reads, a 17-year-old boy returns from a trip to Argentina. He spent time hiking and on the beach and received numerous insect bites. A few weeks after he returned, he developed a gradually enlarging ulcer on his leg. The lesion began as a papule that then ulcerated. He has not had fevers or significant drainage from the ulceration. On examination, he had a 3 cm ulcer with an erythematous base and a raised border. There was no purulent drainage or surrounding cellulitis. Evaluations for bacterial and mycobacterial infections are unrevealing, and a parasitic infection is suspected. So my question to you is, which of the following agents would be expected to have activity against the most likely causative pathogen? Would it be A. albendazole, or B. artesunate, or C. ivermectin, or D. paromomycin, or would it be E. praziquantel? I will give you 10 seconds to choose the correct answer to this question from the listed options. And the correct answer is D. paromomycin. I will clarify why. This patient likely has cutaneous leishmaniasis. Therapeutic options include observation, local treatment with cryotherapy or paromomycin, and systemic therapy with azoles, miltefosine, amphotericin, pentavalent antimonials, or pentamidine. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 226.